in Africa and particularly Nigeria. PPH and some other conditions like eclampsia, pre-eclampsia, sepsis, that's infection, they are the reasons why women die after delivery. And when you talk of women dying after delivery, that's between day 1 up to 42 days after delivery. These deaths are what we rate as accounting for maternal mortality ratio. There is no way to predetermine if a woman will have PPH after delivery. Rather than wait for it to happen and they begin to try to survey things, which in many cases, depending on the level of care, depending on the available human resources, at wherever the delivery took place, it might be too late to do anything. So usually we'll try to do things that will prevent the occurrence of PPH in women.
Smiles for Mothers aims to reduce maternal deaths due to postpartum hemorrhage. The program is being executed in close collaboration with the Federal Ministry of Health, also working with 3 states in Nigeria, Kano State, Lagos, and Niger states. And the aim was to work with the states to come up with context-specific innovations that the states would then implement to achieve the objectives of reducing postpartum hemorrhage and maternal deaths.
In addition to the Smiles for Mothers project, MSD for Mothers has supported a number of research initiatives that have included Nigeria or focused solely on Nigeria. One example is the research study published in the New England Journal for Medicine in June 2018. And this study was comparing heat-stable capitocin and oxytocin for the prevention of postpartum hemorrhage in a vaginal delivery.
Our main function is to develop policies and guidelines that guide different operations, how we put up interventions at the national and the subnational levels. Check guidelines from WHO as they are coming out and adapt it to our local environment, and we run with it. Some of these include focusing on what we call active management of 3rd stage of labor.
The early innovations that Smiles for Mothers worked with the states on was introducing and adopting a recent WHO guideline that make recommendations on the use of uterotonics to prevent postpartum hemorrhage, making sure supplies of good quality uterotonics were available, making sure health workers had the capacity, and even some efforts we did in terms of making sure patients were literate, as well as monitoring clearly what we're doing to measure the success. The very big challenge states were facing was having appropriate uterotonics available in the right quality, at the service point to serve the mothers. And studies in recent times, assays of products available on the field had showed very poor quality, which meant clinicians needed to use multiple doses of drugs like oxytocin, even misoprostol, to achieve the results. So what we did was help the government of Nigeria, both at the Federal Ministry of Health, but also at the state level, to update what's called the State Essential Medicines List. And that expanded the basket of uterotonics they had available, included a new entrant, heat-stable capitocin, which also is heat stable and means it can keep well in our temperatures. So working with that, we then work with the state governments to strengthen their forecasting systems, strengthen their procurement systems, and even look through things like the way they stored, the way they distributed, train the pharmacists and logisticians in the states to then be able to improve availability. And over the 2-year period of the program, we saw a significant decline in stock-out rates of uterotonics across the facilities and improvement in the quality of drugs available at the health facilities.
A key part of the Smiles for Mothers program is to strengthen national and subnational stakeholder capacity to apply human-centered design to plan for the introduction of new innovations, new capabilities, and enhances existing capabilities of a wide range of global health actors by equipping the teams with new tools and methods to understand users, collaborate with them, and design interventions in a more efficient way. We worked with selected stakeholders across the 3 implementing states to build their capacity to use human-centered design, which cuts across 3 phases: co-research, co-design, and co-refinement, to help them to identify gaps and develop solutions to address the challenges that they face with the delivery of maternal health services in their states.
MSD for Mothers supported advocacy initiatives to review the procurement practices for maternal health medicines across the geopolitical zones in Nigeria.
One gap that was there before the program started was the fact that we did not have the heat-stable capital at that affordable price at the health facilities. With the program, we now have it. So another gap that was there, been over 10 years that we reviewed our essential medicines list, and with the program, we're able to achieve that.
In the state, we have over 2,000 primary healthcare facilities, about 26 secondary healthcare facilities, and then 2 tertiary healthcare facilities. And then we would need to reach all the healthcare facilities and then reach a lot more number of the healthcare workers, because they work on different shifts, and then all of them would need to have been trained on the use of the drug and then have information of its effects and side effects.
What the Smiles for Mothers program has done is to introduce the heat-stable capital in Lagos, affordable, accessible, to ensure that postpartum hemorrhage is reduced, and by extension, maternal mortality rates.
With the supply of the seed, about 7,000 doses of heat-stable capitacin, they were able to prevent postpartum hemorrhage, even though they didn't have such a good cold chain.
Another gain from the program has been the fact that the state has been able to successfully use the human-centered design to co-create and co-design solutions to health as well as supply chain issues.
The training of LMCU staff dealing with the logistics, chain management, and the service providers training, it will build the capacity of our system. It will strengthen our system to the extent that the issue of having difficulties in procurement or supply of this HSC in terms of distribution or utilization at the service delivery point.
We also had 2 learning exchange workshops that were done during the Smiles for Mothers being in the state. Healthcare workers were trained about capitation and how it can be used and how effective it is in the prevention of postpartum hemorrhage. And the message can also be passed to the people in the community how postpartum hemorrhage can be prevented, which is one of the leading causes of maternal mortality in the state.
We know the conditions we are in the country. There are so many places that we cannot guarantee light 24/7. There are also places where the heat is so high. And so to avoid this, the Federal Ministry of Health is embracing the use of the heat-stable capitacin. We try to work in partnership a lot, active engagement with manufacturers of many of these medicines to see how we can locally produce these things so that it will be available to our women at a cheaper cost and easily accessible to us. And of course, we make sure that these are also on the essential medicine list so that states and local government authorities can include and be free to purchase those things.
We considered some health financing options mapped out by stakeholders from across the 3 states, which highlighted some of the challenges and successes encountered in implementing services. And from our findings, the DRF scheme was the most functional and sustainable approach across the 3 states. So we leveraged the DRF scheme as the funding source for uterotonics.
Great innovations are good, but if they don't really achieve scale and reach everybody that needs them, then they never really have the desired impact. So on Smiles for Mothers, we're spending quite a lot of effort thinking through what does it mean to achieve scale? What does it mean for more people to learn the lessons that we have and go through the same journey that we had, even better ones, learning from our experience to get the mothers of Nigeria the care they need. So part of what we've done is to make sure, as part of documentation, first of all, we developed what we're calling a Smiles for Mothers program playbook, a guide document on the steps we took, and then capture specific experiences we had, the kind of results we got, but also lessons for whoever wants to take it and apply. So I think that will be very useful for policymakers, health managers, and even implementing partners that are looking to strengthen care in terms of postpartum hemorrhage, but also for other public health interventions, because some of these lessons are very transferable. Part of what we're also doing is to make sure a lot of what we have is published, so even a global audience is able to look into that. But then working closely with the Federal Ministry of Health and bringing all other Nigerian states to the table to say, what does scale up look like of good interventions that have impact like this? How do we prioritize? How do we find and mobilize resources across all that matter to be able to take it to scale? So that's also a very important part of what we're doing on the program.
For the state, since the consortium was only able to reach a limited number of people, it's something that we would adopt, especially the Kankpe Mom app, and then the further train more healthcare workers.
The heat-stable cabertocin is one of the SKUs at the Lagos State Medical Store and is also part of the Lagos State Essential Medicines list. We're going to ensure that there's always funding. Once it's in the Sustainable Drug Revolving Fund scheme, there's always the revolving funds to ensure that it's always available. The capacity building trainings we already have factored into the budget of the Lagos State Ministry of Health to ensure that there's a continuous training of health workers. New and retraining also happens. We also want to ensure that the newly reviewed essential medicines list is disseminated widely across the states so that people know those medicines that are important to meet the needs of majority of the population are at their fingertips. Also, the human-centered design that was used to co-create and solve health problems, we intend to continue to use to, on other issues that come up, whether health issues or supply chain issues, to resolve such.
What we want to see is for cabertocin having been imputed into the essential medicine list for the state to be one of those drugs that will be procured and supplied by the state through the agency.
To ensure sustainability and subsequent state procurement of HSC, we've signed a ceding agreement with the states for funds generated from the sale of HSC to be used for the procurement of additional stock of HSC. This will ensure that women have access to quality uterotonics in each of these states.